Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. We are explaining the unit concerning financing and insurance in healthcare, that is unit number 5, and in this particular lecture we are emphasizing on adverse selection as part of the information problems in healthcare. In the previous lecture we emphasized on moral hazard in healthcare. We have discussed its what is the concept of moral hazard, then types, the determinants, then also how to limit moral hazard or control moral hazard so that the market might function well, its evidence and upside of moral hazard, etc. were emphasized and discussed. In this lecture we will be discussing on adverse selection in health insurance in particular. Adverse selection, as we know, it has two sides. One is information asymmetry has two sides. Adverse selection is one of the important part of the information asymmetry. Another one is moral hazard as a problem of information asymmetry. But important aspect to point out here is that which one is direct and which one is indirect, or which one is hidden action, which comes first or which occur little later, etc. We will discuss. Asymmetric information is often studied using a principal agent problem in which a principal offers a contract to an agent who has private information. The two main variants of the principal agent model are the model of hidden actions and hidden types. So, one is action and another is called type. In principal agent model, that is precisely called two-part model, in which the party possesses the contract and it is actually called the principal. The party who decides whether or not to accept the contract and then performs the terms of contract is called the agent, if the contract is accepted. Then moral hazard problem is discussed either after or before the event. We are just discussing at this moment. It is called hidden action model, and usually moral hazard happens after the insurance is bought. There is information asymmetry between the two parties, and hence it is called hidden action model. So in short, we already discussed this. Moral hazard refers to the situation where one side of the market can't observe the actions of the other. For this reason, it is sometimes called the hidden action problem. Okay. In contrast, the adverse selection is referring to the situation, or this refers to a situation when one side of the market cannot observe the type or quality of the goods on the other side of the market. For this reason, it is sometimes called hidden information problem. This usually occurs before the insurance is bought. There is information asymmetry between the two parties, and hence it is called hidden type model. The previous one we said hidden action model, and it is called hidden type model. So, adverse selection refers to a situation where either the buyer or the seller has information about the aspect of the product quality that the other party does not have. The other party with less accurate information is usually at a disadvantaged stage, since the other one has taken the advantage. The imbalance in information leads to inefficiency in the insurance market. We are actually going to discuss. For this, we are referring to Judge Akerlof 1970 paper, starting with lemon market and plum market. with seller and buyer identity, with some convergence in their contract in the market. Lemon used to be defined as soft quality products in the market, and plum is considered to be relatively better. However, both the terms are actually slangs. The plum is considered to be a slang for the good car market, and lemon is for the bad car market. In this case, we are just trying to say a maximum possibility is taken in terms of buyers and then sellers. So, seller willing to sell for the plum the market for this car as a good one, minimum of $2,000, whereas the buyer might be quoting at maximum till 2400, and there are some possibility of averaging. For the plums, the range is between 2000 to 2400. Any contract or the rate in between is fine. Similarly, for the lemon market, this might be actually holding better for the final solution, but we will see how it works in the insurance market. However, this does not hold in market with information imbalance, that is, sellers can identify lemons and plums, but buyers cannot do. In this case, sellers has the information about the quality of the car, whereas the buyer does not have. But in case of insurance, it is just the reverse. We are going to just discuss. So, what happens to the market if buyers cannot observe the quality of the car? Then there might be subcontracting, or might be bias towards the selling of the product. In the case of information asymmetry, the buyer will be willing to take car for the expected price of the plum and lemons, that is it has probability, let us assume by 50% probability. So, the buyer says the probability of 1200 and for the lemon market and 2400 for the plum market, hence the average, the expected price is 1800, that is the one buyer is willing to pay. But this price only lemon sellers will be happy to be in trade. Plums can actually go out of the market, are actually going out of the market. Hence, it seems that the the bad car or the bad segment or the bad quality is actually overcrowding the good quality. So, low quality items crowded out the high quality items, buyers will end up with adverse selection. This leads to inefficient market and hence market failure. Okay. So, since inefficient products are going to be sold, since lemon market actually exists at this expected price, hence this leads to market failure. Plum owners must signal to prospective buyers about their quality for market correction. Hence, signaling is one of the solutions we will also discuss. Market for lemons in health insurance market in particular, where similarly the insurance contracts whether to pool of individuals with high or low health risk. Insurance company used to sell their product with certain expected labels. Insurer has no information or risk classification of the people. They set premiums based on average data of common pool. Okay. However, at this premium, high risk people will be happy to take insurance since they are getting better deal, and low risk people will refrain from signing the contract or taking the premium since they will be taking a high premium deal for them. Hence, what is actually ended up, the high risk people has paid the premium at a low price rate because of the averaging or the common pool issue. So, then they end up with paying less, whereas the low risk one, their percentage used to be very high. They used to be covering the market with their numbers. Even the incidents are very high with the other categories. Since they are not opting for the insurance, hence the insurance market is not capturing more coverage, since they are refrain from signing the contract. This leads to inefficient market for insurance as well. Okay. I think this case we have discussed even in the previous one for the car market we also discussed. One difference is that in this case we are emphasizing about the buyers In the previous case, we emphasize on the sailors. In both the case, it has market failure aspects. Compulsory insurance for all will be a solution for market correction, but it is very costly affairs as well, and if public policy is very active enough, and then that way it will work. Here information imbalance occurs, as I already said. In the used car market, the sellers has the information about the quality of the product, whereas in case of insurance market, you will see the buyers usually know the situation. Okay, so and then okay, some of the models will be emphasizing where how insurance market works and how adverse selections are actually dealt. Ekerloff presumed, especially we are referring to Rothschild and Stiglitz model 1976. We start with the reference to Ekerloff presumed risk neutrality in his adverse selection model. Rothschild and Stiglitz improved it by considering risk averse behavior in individuals. Heterogeneous risk types are the one, we are actually clarifying these things. There are two types of individuals with different risk are present: frail and robust. Frail person is more likely to fall sick than the robust one. Model discusses two types of equilibrium, hence either it is pooling based or separating based. Pooling, where as I told you, a contract that attracts both robust and frail customers and simultaneously satisfies the equilibrium conditions, whereas in case of separating equilibrium, a set of two contracts that satisfies the equilibrium conditions, one that attracts robust customers and another one that attracts the frail customers, and in that case we'll just see what is happening. Predictions by this model, Rothschild and Stiglitz, is that there will be no pooling equilibrium or no equilibrium can exist. Why it is? Because the resilient individuals, despite being risk averse, are unlikely to willing to support vulnerable individuals in an insurance market. While insurance market effectively distribute risk among those with similar risk profiles, they are not optimized for pooling risk across population with diverse risk profiles. Whereas in the presence of a separating equilibrium, individuals with frail health conditions will have complete insurance coverage, but will be charged a high premium per unit of coverage. On the other hand, individuals with robust health will have partial insurance coverage accompanied by a lower premium that signals or that aligns with their lower health risk. So, this is what the predictions given by the model. Now, we are actually linking the adverse selection in real market context as per the RAND experiment, RAND health insurance experiment. We also discuss a bit in different modules of our course. Referred to the work of Marquis and Phelps in 1987. Participants were asked to make predictions of their own healthcare cost for the coming year and how much willing they are actually to purchase insurance policy for the coming year. Families with high predicted values for healthcare cost were more likely to offer health insurance. They actually incurred high healthcare cost in the following year. In normal setting, this could not be predicted by insurers using demographic factors simply. Information advantage to customers of health insurance, but actually the information more is there that will actually be helpful. So, a real market context, other studies are also there, other studies showing a positive risk coverage correlation, such as low income Mexican familiar, as mentioned by Spenkuch, I think low income Mexican family. Okay, so and elderly Medicare beneficiaries mentioned by Brown and Finkelstein, Harvard professor and staff, etc. There are some other studies derived the evidences. Again, there are some evidence which are against adverse selection. I think I must mention in the context of advantageous selection. A study by Pang et al. 2008 observed negative correlation, not positive, between risk and coverage. Okay, healthier beneficiaries disproportionately opted for supplemental insurance policy. Seniors who opted for insurance incurred about even 4,000 US dollar lesser on average. So advantageous selections occurs because seniors with better cognitive ability were healthier and more likely to purchase even health insurance. So this is basically advantageous selection is basically a phenomenon where less risky people are more likely to purchase insurance than the more risky people. This may occur as less risky people are more risk averse. Okay. Wealthier or better ability to understand the benefits of insurance, since they understand better, hence there might be some reverse evidences. Okay. What prevents adverse selections? Four possible reasons. I think not to explain much. Customers misperceive their own risk. Customers do not act on their private information. Insurers can accurately observe customer risk, and selection on other factors such as like their cognitive ability, risk aversions, extent of risk aversion, overcome adverse selection and health risk. So these might prevent adverse selection problem. So some of those there are three predictions of asymmetric information models. One is called positive correlation between risk and coverage, another is called bull markup, and another is called adverse selection death spiral. So far as positive correlation between risk and coverage is concerned, there will be a positive correlation between these two. Customers who are more likely to rack off insurance expenditures should be more likely to have insurance policies, whereas in case of bull markup, insurers will use bull markup in their pricing strategies. Customer with more insurance coverage should have not only higher pay higher premium, but higher per unit premium as well. So that is basically called the markup is actually doubly loaded, okay, and can be discussed in the context of information asymmetry. Adverse selection death spiral, where pooling between different risk type peoples cannot survive in the market in the long run. However, some inducements such as legal mandate or subsidy may prevent lowest people from dropping out of the insurance. There are some countermeasures to reduce asymmetric information called signaling as proposed by Michael Spence. Here the concept is clarifying some signals exhibited by buyers or sellers, like the buyer or the seller signal the other uninformed party to increase their information about the product in trade. Uninformed party provide information to the informed party provide information to the uninformed parties, and reverse where they are actually expecting the better. So the informed party provide information to the uninformed parties, isn't it? So in the labor market where high and low ability workers are present and are not easy distinguishable, employing somebody can be very costly to the potential employer. If an employer hires a low ability worker for a job requiring for a job requiring high ability one, he will be in severe loss. In such a case, market signaling works really great. The high ability workers can signal the employer about his abilities and which stands out among the low ability candidates. Signals could be in the form of better resume, maybe through their resume submission at the time of application, maybe being highly qualified, education level, showing good etiquettes, speaking decent language, etc. are called signaling, which reduces the information asymmetry. Another one is called screening. If you have a better screening of the candidate or regarding car or even health insurance market, would actually correct the information asymmetry. What is then the difference? One is called signaling, explaining, exhibiting information, whereas the second one is the party or the seller is actually deriving the information. through screening. Uninformed parties initiate communication by conducting a test either for the informed parties or the goods those parties seek to trade. Basically, there should be further communication. Just citing one example, that is in the second hand market, the potential buyer of a second hand car can learn about its quality by getting it checked again from a mechanic or learn about accident record of the car. Similarly, you please go through this health insurance company and their signaling strategy and will help. In this case, the difference which you just said, what is the difference between screening and signaling? It matters who gives information to whom. There you can find out the clarity. Similarly, there are other measures to counter the information asymmetry. Is called warranty, mandatory information disclosure, incentives and penalties, etc. Some figures I just want to mention about health insurance market in India. We are taking the figures from the most authentic source called IRDAI, where we discuss about the insurance density comparison across countries. You can just see and highlighted the India's figure, and their density is much lower than other countries, and number of health insured person as per the IRDAI figure till the 21-22 age is not still very impressive. Still it shows that rising from 2013-14, but it seems very stagnant in the recent years. Number of persons in thousand covered with health insurance in India is also presented by their standalone package or by private insurance or public. Still the public insurance coverage is most dominating, and you can follow for your work. Here we are giving a timeline of social health insurance and government funded health insurance schemes in India, referring to the work of Lancet 23rd paper. We start with the initiation year of 1948 with the introduction of employees state insurance scheme, which has both state and center scheme. So and similarly we are also emphasizing on other scheme over the time, and to mention a few we have explained here. Employee state insurance scheme of India 1948, where this is for the blue collar workers of the organized sector that is part of the ESIS, which was started under the Employee State Insurance Act 1948, and this is still working. And there are some financing aspect and coverage aspect we discussed. The scheme is financed by contributions from employers as well as employees. The company contributes around 3.25% and the employee contributes 0.75% for all employees earning rupees 21,000 or less per month in salary, for a total share of 4% in total. This scheme has a coverage since it started in 1952 from Kanpur and Delhi. Today it covers 33 states and UTs and applies to 7.83 lakhs factories and establishment across country, benefiting about 2.13 crore insured person or families. Total beneficiaries are 8.28 crores. Health insurance and its evolutions starting from 1954 from the CGHS, that is Central Government Health Scheme, and used to be for the central government employees and the families. We are referring some important timeline where in 1986 the insurance was mostly with the GIC, General Insurance Corporation, GIC physically launched the India's first Mediclaim policy, but famously known as GIC. This is considered to be a voluntary health insurance scheme. This exclude pre-existing disease, pregnancy, childbirth, HIV AIDS, etc. In 1991, after the new economic policy and liberalization process, privatization of insurance sector had taken place. And the regulatory body, that is IRDAI, Insurance Regulatory Development Authority, was set up in 1999, and this is considered to be the prime body in this particular sector. To emphasize the important scheme called Rashtriya Swasthya Bima Yojana in the context of healthcare, it was started working in on April 1st, 2008, and the objective was to provide protection to the BPL families and from financial liabilities arising out of their health shocks because of their incidents of hospitalizations. The eligibilities are like unorganized sector workers belonging to the BPL category and their family members. Usually the family cap is restricted at 5. The total sum of benefits were actually 30,000 rupees per family per year on a family floater basis. All pre-existing diseases to be covered, transportation cost etc. are also discussed within this scheme or Yojana. Within limit transportation cost as part of this Bima Yojana is covered as 1000 rupees. Funding, who is funding is Government of India and state government both, and also beneficiaries would pay rupees 30 for year as their registration or renewal fee, and this is subsumed under under the famous scheme PMJY in the recent time. Okay. Jan Arogya Yojana, Pradhan Mantri Jan Arogya Yojana. So RSBI is no longer defined, now we are actually referring to PMJY. So another aspect scheme is called Senior Citizen Health Insurance Scheme, provided insurance coverage to senior citizens as a top up cover for the RSBI scheme. Additional coverage of 30,000 rupees per senior citizen to the eligible RSBI beneficiary family. Later on again this is also subsumed with PMJY. Another important policy is called as I already told you, which the latest policy is called PMJY. It is not just the coverage of the RSBY, it is the health insurance component under Ayushman Bharat scheme of Government of India, also known as National Health Protection Scheme. It was launched on October 23rd, 2018 in Ranchi, Jharkhand. It subsumed the RSBI, Rashtriya Swasthya Bima Yojana in 2008. The RSBI scheme was introduced in 2008, and this program PMJY actually has covered this and also covered senior citizen health insurance scheme. This is funded by government, and insurance cover was of rupees 5 lakh per family per year for secondary and tertiary care hospitalization across public as well as private. That this is important to mention, and then private empaneled hospitals in India. Okay. So no restriction on family size. Earlier family cap was 5 members, or no restriction on age, gender, and the pre-existing diseases are also covered from the very first day. So there are important features and follow. So these are all we need to just summarize what we did in this lecture. We discussed about healthcare financing. Okay, so what we discussed actually all about is healthcare financing, resource allocation, health account, uncertainty and health insurance, asymmetric information, that is moral hazard. Then we also emphasize in this particular lecture, this is the total summary of the week, and we are actually emphasizing in this particular lecture adverse selection, and we did it. And here are the readings for you. I think it will be useful, and I hope you have raised some queries. We will be happy to address it in the respective lecture. Thank you. So we are going to stop here. Thank you.